I'd like to introduce Nancy Owens. Nancy, I'll let you tell everyone about yourself.
Yeah, I can talk about myself.
Yeah.
Let me give the people who came in, who doesn't have Post-its. Oh, you can do that.
I can do it.
2 Post-its.
Okay.
Everybody has 2 Post-its.
Literally.
So my name is Nancy Owen, and I'm a licensed mental health counselor. I have a private practice in Kirkland, and I'm a certified sex therapist as well. And I'm very excited to be here with you, especially after hearing what you all do. I need people to refer to. So if any of you have like cards or things that you can get to me afterwards, that would be great, because I'm always looking for people who can work with individual clients, couples clients, who know how to do this sort of work. It's super important, as you would say. So a little bit about me. I have been a therapist for going on 28 years. So a really long time. I've kind of, as many therapists do, taken a kind of winding journey to the clientele that I work with now. My first 10 years of practice, I worked in community mental health, and I worked with kids and families exclusively, with a pretty strong focus on the 0 to 3, mother-infant stuff, all that. Worked in a Head Start program. And then toward the end of that little journey, ran a program for violent and assaultive youth. So kind of went from the 0 to 3 to teenagers who were in the juvenile system, and kind of ran that program for a couple of years, and then took a hiatus. Somebody was saying they were on hiatus for a while. I took a hiatus to be at home with my own 2 for about 7 years, 6, 7 years. And then we moved from North Carolina, you can probably hear that in my voice, most people ask, to Washington, to the Seattle area. And I still had littles at home, so I was like, I'm not gonna do the therapy thing anymore. I'm just gonna figure out some other thing to be, because 10 years in community mental health is a long time. People say 10 years. I did 2 years and I was out of there. I'm like, yeah, I'm a stayer, right? I just get somewhere. It was great work, but I was burnt out and was kind of like, okay, I'm going to do something other than therapy in my life. And then I tried some other things and and I was like, I'm a therapist. That's what I am. So I made my way back into the field. Had to take the licensure exam out here, which was pretty scary, being out of graduate school for like 18 years. And then they say you have to take that exam again. So I did all of that, got the certification, got the licensure, got all those things. And then the second half of my career has been all adults. And for some reason, I migrated to couples, which in graduate school, I don't think I would have ever seen myself go that route. But I started working with couples, started loving it, and then did all kinds of training to figure out how to do it. Because those of you who are LMFTs know how to do that. I'm trained as a clinical psychologist. So I had one class in graduate school in marriage and family therapy, and we never talked about sex ever. Oh, granted, this was we don't need to say 30 years ago, but no sex training at all. Oh, there we go. We have lots of echoing. So to do couples work, as I started doing couples work, we're talking about sex. If you're a good couples therapist, you are going to talk about sex, of course, although don't take that for granted, because some couples therapists don't feel comfortable talking about sex. But I was always talking about sex, and then realized I need more training. I'm making this up as I go. So went back to school to become a certified sex therapist and got all that training. And in the meantime, worked for about 8 years in a perinatal health program. And so that's where the focus on this period of life really came out for me. I was working in an agency with lots and lots of couples and families transitioning to parenthood. Did the Bring a Baby Home class, if you're familiar with that, the Gottman class. So I led that for about 8 years with bunches of couples, and just love this period of life. And it's just so exciting to hear that you all do this work. And so we're going to talk a bit. So what I want to say about myself is I'm a therapist. That's it. I'm not a doctor, not a midwife, not a doula. I'm not a pelvic floor PT. And so I'm so excited to have all of you in the room because so many of you do other things than I do. So my presentation is kind of from the therapy side, but I would love it to be interactive. I would love to have you all chime in and talk and say the things that you do and the things that you know, because you all know a lot of things that I don't know coming from the therapy side. I've been to lots of trainings and tried to learn as much as possible, but you can't know all of the things. So I would be glad to hear what all of you all have to say as well. Okay, so the first thing I want you to do is to take those 2 Post-its that I gave you. And if you have something to write with, hopefully you do. This is kind of a word association. I'm going to give you 2 words, one at a time. And take one of your Post-its. I'm going to say a word. I want you to think of the first word that comes to mind when you hear that word and write it on that Post-it note. Make sense? Okay. On the first Post-it note, whatever color you choose, the word is sex. First word you think of, just jot it down. Try not to give it too much thought. The second Post-it note, same thing. Going to give you a different word. Going to have you write the first word that comes to mind when you hear childbirth. And once you are done with your 2 Post-its, let's see what we're going to do with them, because I would like to have them somewhere. Let's do, what do you think? We could pull it out a little. We could pull that out a little, or we could use the walls, I think. I just want to have them. Let's put the sex ones here, and let's put the, pull that out. Yeah, we can put the childbirth ones here. Yeah. And that'll get you to move around a little bit. So put the sex ones here, the childbirth ones over there. Sex. Yeah, sex over here. Okay. Childbirth over there. True. Some similarities in there. Mm-hmm. Beautiful. All right, so interspersed in my presentation, I have thrown up some tweets where people have tweeted about sex after parenthood, which I like because they're funny and they're also really relevant to the work that we do, understanding where people are. Can you guys read that okay? I don't know if it's big enough. Okay. Most often we fall asleep while discussing the possibility of having sex. It's great. Okay. Before we start talking about pregnancy, let's see what the words were. So for sex, I love that word, wow. Lots of intimacy. Lots of people wrote intimacy. Women, bodies, relaxed, fantastic, love it. Comfort, connection, fun, touch, pleasure, vagina, complicated, intercourse. Okay, so those are the words you guys came up with. So childbirth, pain, intense, strength, yes, hard, blood, another pain, labor, beautiful, painful, pain, ouch, pain. All right. I love it. Okay. The interesting thing about that, you guys put the right words up there. We're really hopeful that after people give birth, that all those ouches and pains, they kind of migrate sometimes for people over here. And I mean, it can be really, really meaningful to work with couples and families after this period of life, because often this is the first time that they experience sex as painful or complicated or difficult or intense. A lot of those words over there, they come over here, and we don't talk about it like we need to. Doctors don't talk about it. General culture doesn't talk about it as much. We're starting to, and I'm happy that the conversation is kind of starting to happen. But I still have way too many women in my office who come in and are embarrassed to talk about how painful sex is for them or how much it's not working because they think they're the only one who's having this problem. Do you guys experience that also? Okay, I see heads nodding. So we're not where we need to be then as a culture. We're not where we need to be if women are still feeling like this doesn't happen after childbirth, that things don't change. Everything changes for childbirth emotionally. There's lots of things happen. So we're going to talk a bit about that, and hopefully we're going to have a conversation. All of us are going to have a conversation about that. And I'm going to try to talk about pregnancy, and I'm going to try to talk about postpartum kind of as a continuum. But anytime you have something you want to say, just, throw it out there. And anytime you want to get up and move around, also totally cool. So let's talk about pregnancy first. So, I'm going to need a little bit of, those of you who are medical folks in the room are probably going to have more that you can chime in for me on this. And there's a list of resources that I put at the end of the slideshow too. And you may also have things you want to add there. So let's talk about what happens during pregnancy. So in your experience, when you work with pregnant women, what are the sexual concerns that they talk about, if any? What are the intimacy concerns that they discuss? What are things that come up?
I hosted class, and so many people bring up they're scared if they have sex, they'll have a miscarriage.
Yes. Yeah,
So
that's huge.
we talked about that a lot, how that's not going to happen.
Doesn't go together.
Yeah.
Yeah. And I've actually have had a lot of partners who are also incredibly afraid of that as well. So sometimes it's not the pregnant person, but the partner who is really afraid to be physically intimate because of that fear of miscarriage. What other concerns have you heard folks have around pregnancy?
I would just say that, I feel like when people are talking about sex, they're talking about intercourse a lot of times, and it's very heteronormative in that way. And just then when the discussion of sexual intimacy comes up, it's not even as much chartered, or I don't know, it's just looked at differently, the intercourse piece.
Yes, yes,
versus
for sure.
other stuff.
Versus other things. And one of the things that we're going to talk about for sure is that continuum of sexual intimacy has so much more on it than intercourse. But many folks fall on that's sex to them. As a sex therapist, one of the first questions I ask when folks come in to talk to me is, tell me what sex means for you, because I don't assume that I know, right? And that's a really helpful thing to talk with your clients about, is have them talk to you about what sex is for them and their partner or partners. Yeah. Other concerns you've heard come up about during pregnancy?
I think there's a discomfort with their own body, so for the pregnant person.
Okay.
And then I think there's also a discomfort with anything around pregnancy or baby being erotic. Right?
Yeah.
So there's this fear, this white hot, can't touch that. And so, but they're pregnant. And so it sort of just makes sort of the whole, idea of having sex or, being uncomfortable.
Yeah. And I think that brings up a really important thing to think about with folks, which is that motherhood and sexuality problem that we have in our culture, right? We have a major issue with the crossing of those two things, being sexual and being a mother. really brings up a lot of issues for folks, and for different reasons, but it's a cultural thing for sure. And women often start to feel that for the first time, that kind of dichotomy when they are pregnant. So, I mean, that's a really good point to think about. And sometimes something they can't put a name to themselves, but there's just something wrong about, you know, having sex if I'm pregnant, if I'm a mom. Feeling aroused and being pregnant can be very uncomfortable for people. Also, the partner can feel uncomfortable being aroused and having a pregnant partner as well. That can also be a thing. Am I a pervert? Is there something wrong with me that I feel aroused by my partner being pregnant? So, and these are things, again, if we're not talking about it, people aren't going to talk about it. It's embarrassing. It's difficult. So you being a person who's comfortable with all of those conversations, can't tell you how huge a relief that is for folks when we voice it, when we put it in the room and just ask it. And people feel like they can talk about it more. Yes?
I think in pregnancy, what I notice is the starting of the concern about their decrease in libido or sex drive, and then how that's going to affect their relationship post-birth, because everybody's heard like they're not having a bunch of sex post-birth, and how are they going to? So I feel like that unfair burden is placed upon the birthing parents, usually the woman, but it's like, so the male with, you know, I'm speaking heteronormatively in this moment,
Sure.
you know, in that sense of like the testosterone is always ready, that sort of thing. And it's just like the pressure from that partnership to fulfill a certain role that may or may not be true that she needs to fulfill for sexual duty, but there's some like latent imprinting that goes on that seems to amplify in postpartum, and something's wrong with me. I don't want to have sex, I'd just rather sleep. So really having to work on some of those imprinting.
Yeah. And that issue of libido we're going to talk about throughout the presentation. The issue, those of you who work in mindfulness and use kind of mindfulness strategies with your clients, it's really relevant to begin to talk about libido in a different way. I talk a lot with my clients about, they come in and say, well, I have low libido. As though I tell them if there's like a canister of it, and like your canister of libido is running low. Like there's somewhere in your body where you hold the libido and it's either there or it's not. We start to talk about desire in a different language. Instead of using libido, I often talk about desire. And sometimes you feel desire and sometimes you don't. And we'll talk a little bit about that a little later, but I think the idea of libido and the idea of low desire, it is often in pregnancy when the pregnant person begins to experience, maybe for the first time, lower libido, less desire. And it can be really scary for people to feel like, okay, that's gone, and is it ever going to come back? I'm not sure. Is it ever going to come back? So some of the things that happen during pregnancy, as you all know, increased blood flow. So the vagina, the vulva engorge with blood. There's a lot of blood flow there. You can have the skin around the vulva, around the vaginal mucosa looking blue. You can have increased vaginal discharge, and sometimes you can have bleeding, which can be really scary for people. And sometimes you can have bleeding after penetrative intercourse as well, which can be really scary for people. So that's where that fear, as you were talking about, around we had sex, we're having a miscarriage, can be incredibly scary. And as you know, anxiety and sexual arousal don't usually go very well together. So if folks are feeling anxious about having a miscarriage or about hurting, I hear a lot of partners worry about hurting the baby or hurting the partner. If that's the case, sometimes people can have trouble with arousal. Lubrication, erection, those things can not happen like they usually would because anxiety is coming in around what's going to happen. So it's important to begin to talk with pregnant clients about this. Yeast infections, more common. There are, what do you find with libido? I think I made some comments here. Okay, so as you were talking, you've already said penetrative sex doesn't have to be avoided during low-risk pregnancies. There isn't really a statistical kind of connection between miscarriage and having penetrative sex during intercourse. Sexual intercourse close to the due date, there really isn't too good of evidence that it triggers labor either, although there are a lot of urban myths to that effect. Nipple stimulation can sometimes help to stimulate labor, sometimes. For higher risk pregnancy, sometimes physicians do recommend avoiding sexual activity in these particular cases or some others. What do you find about desire? What are your clients tell you about desire? The research tells us that the decrease typically happens during the first and third trimesters, and that the second trimester sometimes is a period when people feel more desire. So that's statistically, but do you find anecdotally for your clients that to be true, or do you find differences? Yeah, pretty much. And I mean, it varies. I mean, that first trimester is often when people are experiencing some nausea, not feeling great, a lot of fatigue often during that first trimester. So sometimes people don't feel particularly aroused during that period of time. And then in the third trimester, you know, your body's different. Your body's bigger. Certain positions are really uncomfortable. So, you know, and all of these physical changes and symptoms that happen, as we know, can impact people feeling like they want to have sex. Do you feel like that with your clients, are they having conversations with their doctor about sexuality during pregnancy? Not really? Not so much?
Or their partners. That's what I thought you were going to ask.
Oh, with their doctors. Yeah, well, anything about their concerns, or with their healthcare providers sometimes? Sometimes, yes. They do talk to you. Okay. You're a midwife, right? So they do talk to you about sex. Okay. And I'm imagining you're bringing it up as well for them to talk to you about it. Okay. Yeah. Yeah. I mean, one of the things that I think will help us in our culture to combat this, no, moms don't have sex, or moms don't feel desire, is us talking with pregnant women about sex, and us talking about sex during the postpartum period, right? If we bring it up as a natural, normal conversation, then it begins to break the taboo around, you know, if you're a mom, you don't want to have sex. So
I think an important piece of this is we focused a lot on the decrease, is that they have an almost equally difficult time bringing up their increased libido.
okay.
It's because of our culture of slut shaming.
Yeah.
It is really hard for them sometimes to talk about how much they want
They
to
really
ride
want-
their libido.
Yeah.
So I think that it's really important as a part of the entire sexuality in the childbearing year to also talk about the positive parts and the way that sex is very positive in pregnancy.
Yeah. Yeah.
And that's part of, on the previous slide, the third trimester, I was thinking about it, and I think it's almost 50-50 for folks who either like see a really big increase in their libido, or a big like, I'm a whale, no position's comfortable.
Yeah.
And then the shocked face. I hop up and show you different ways they can
Yeah. Yeah.
Yeah. So they're
That's super helpful. So some ideas that I talk about with my couples around, and this is, some of this is like, I talk about this with every couple, whether they're pregnant or not. Obviously, communicate. So let's talk about communication for a moment around sexuality. So first of all, how are we taught to communicate about sex in our culture?
Don't do it.
Yeah.
Don't talk about it. Okay. What other messages do we receive about sex?
Hush tones in private, not using technical
Rewording.
names. Yeah, rewording.
Right.
Like,
Do
you know,
get
that-
intimate?
So using innuendo, using innuendo, not, A lot of the body parts also often are not, we don't use the anatomically correct terms for body parts. What about with our partners? How do we learn to talk with our partners about sex? Do we? What's sex education like? It's abstinence-based, right? Pretty much.
Or fear-based.
Fear-based. So what do we teach in sex education in the United States? And again, keep us to the United States, because some other countries are doing this better. I'm getting ready to go to Amsterdam in a few months to learn how they do sex education, and I know I'm going to come back really sad. Right? But you know, we can learn and we can bring back those things. So what's it based in? It's based about fear. What do we teach? STIs and pregnancy avoidance. Period. Right? So I have two teenagers. I have a 20-year-old and a 17-year-old, and it can be really hard to have a sex therapist as a mother. So you can ask them. They're probably going to be in therapy for the rest of their life. But unfortunately, this is, I mean, and I think some of it they actually appreciate, whatever. But one of the things that I talk about constantly is the word pleasure. We talk about pleasure all the time at our house. Pleasure. And I mean, my 17-year-old says, if you say pleasure one more time, I swear, please don't say pleasure in front of my friends. Right? And I understand that. But I mean, there is no pleasure in the sex education curriculum. We do not talk about it. We do not talk about pleasure. What is the purpose of sex? Pleasure and procreation. I put that over there. We're talking about pregnancy. So procreation and pleasure. Primarily pleasure, actually.
Right, like a lot of times we'll do it for procreation.
Yeah, think about how many times in your life you have sex for procreation and how many times are not for that. Right?
How many times you help people procreate without any sex at all?
Yeah.
Right,
Yeah.
right. So, I mean, it just boggles my mind that we are not teaching young people about pleasure. If you have not read Peggy Orenstein's 2 books, are you familiar with those? Peggy Orenstein's written 2 books, Girls and Sex, Boys and Sex. The Boys and Sex one just came out like a month ago. The Girls and Sex one several years. They're kind of heartbreaking because to me, I was hoping when I read Girls and Sex, because I have 2 girls, that we would be farther along in the teaching of pleasure-based sexuality than when I grew up in the evangelical South a long time ago. I was really hoping that. Not so much. I mean, what the books are is she's done interviews, pretty extensive interviews with young people between the ages of like 14 and 25, all kinds of information about what they think about sex, what they think about their sexuality experiences that they've had, interactions. And what we're finding is that they don't have the information they need. It's not about pleasure. It's about fear and anxiety. I mean, we're learning what we kind of knew. I was just hoping that we were farther along than that. And kind of we are, which is sad. But it does give you a nice picture of probably where some of your clients are coming from when they're trying to communicate with their partners. So why would you need to communicate more about sex during this period, during the pregnancy period, do you think?
So a lot of things are different than they maybe were before.
A lot of things are different. A lot of changes are happening.
I think too, if you go back to the perspective of sex for procreation, that's a done deal. So what's it for now?
Now what do we do it for? Mm-hmm. And that's a good point to bring up as far as many of your clients may have taken a very long and difficult journey to get to pregnant. So don't forget, for those clients who have perhaps been through infertility, you were mentioning miscarriage and pregnancy loss, which I have a lot of clients as well who come from those places, that once they get to pregnancy, they have had a lot of loss and grief happen before they get there. So what is sexuality about then? How is sex to happen? Because sex has been for a very specified purpose within very clear guidelines for months and months, sometimes years. And now we're pregnant. So we can have sex whenever we want. For what? Why would we do that? There's no calendars, there's no ovulation kits, there's no. So think about that if you're working with clients who have been through infertility, who've been through miscarriage, pregnancy loss. It's a really different thing for them as well. Why else would you need to communicate during this period?
I always talk to my patients about that the positions they may have liked pre-pregnancy, they may not like now, for everybody involved, and certain positions may be painful or
Yes.
uncomfortable, especially
Yes.
with like direct cervical
Uh-huh.
touch or pressure. So I always just, and you can have cramping, and when you have an orgasm, you can have cramping.
Yes.
Like, so it's like all this stuff that I'd like you guys have to talk about it and roll with it. Your first trimester is going to be different than your second or third post. Like,
Yes.
so I'm just like, you just got to roll with it and talk to each other.
Love that. Love that. And I love that you said it's going to change throughout your pregnancy as well. So it's not that you need to communicate just at the beginning of the pregnancy. You need to keep talking because things may change and things may shift. Your desire may shift. Your positioning, you may need to change that around. There may be pain or things that are uncomfortable. And so continuing to chat with your partner about that, and partners continuing to chat with the pregnant person, those things are super important. What about the partner in this situation? What about that sort of communication? What do you think comes? What do you think comes up for partners around sexuality when their partner's pregnant?
I see a lot of guilt.
Okay.
That comes up, a lot of shame.
Can you say more? Guilt and shame for?
So what you were touching on earlier about, having sex with my partner who's now pregnant, having desire that looks a little bit different.
Yes.
Maybe having developing a little bit of fetish or something like that,
Mhm.
and having a lot of shame around, am I gross now? Am I a perv?
Yep. So that's pretty important.
I guess I think of that I see a lot of that there was some underlying sort of miscommunication, lack of communication, or sexual problems in the relationship before pregnancy. And then pregnancy and postpartum come along and exacerbate it because there's often less sex. Not always, but like, so there's less sex for lots of other reasons than before.
Mhm.
And then perhaps the pregnant person starts to realize like that they don't want to be having sex as much because of maybe there was some, like, they weren't feeling as much pleasure as they wanted to, or there's a little piece of like, we're pregnant now, so why do we have to do that? But I don't think that's the whole picture.
Yeah. Yeah.
And they realized that they were doing it before for other reasons than for pleasure, and now they kind of can't muster it.
Yep. And I think that brings up a good point about taking a sexual history with your clients. Figuring out sometimes the issues that arise around sexuality during this period predate this period. Sometimes there are issues that have been with the couple perhaps from the beginning, or perhaps there have been things that have happened during the relationship that have kind of thrown sex off track and have created a situation in which sex doesn't feel good for one or both partners. And so it's important to investigate and be curious about that with your clients, not to assume that the pregnant partner is experiencing a loss of desire because of the pregnancy. There may be other things that are happening as well. Perhaps there has always been low desire, or perhaps there are issues in the relationship that don't relate to sex that are playing themselves out in the sexual arena. Sometimes that can happen. Difficulties in communication, anger issues, or resentments that have built up over other things that play itself out around the sexual script that they have. Yeah, trauma, absolutely. And we're going to talk about trauma in a minute as it relates to childbirth, but for sure, knowing that your client or both partners have a trauma history is something that you're going to want to look into, because it's going to impact being able to communicate about sex, even being able to communicate about pain during sex, being able to communicate that something doesn't feel good. If we go back to the idea that sex is not about pleasure, then it becomes really difficult to tell your partner when something's not pleasurable. who cares if it's not pleasurable? That's not what you've been taught sex is about. I've been working with a couple for a number of months, and the female partner, this is a heterosexual couple, the female partner has a fair amount of trauma in her background. And we were taught, I've taken a fairly extensive sexual history, but understand that we keep uncovering things because it's hard to get to those things at the beginning. So we just keep uncovering things that are happening. And the questions that I ask sometimes lead her down a road where she's like, so she brings up this week, when you were asking me the other day, are there ever times when you come in and you see your partner and you just feel like you want that? You're aroused, you're feeling like desire for your partner and wanting to have sex. And she said, I thought about that. That was like 3 weeks ago. She said, I thought about that, and I thought about that, and I thought about that. And I realized, nope, it's never happened. And then I thought, okay, then that's not okay. That's not okay. So I thought about that, and I thought about that, and I thought about that. And she said, I thought back on all my other relationships that I've been in, all my other sexual partners. And she said, I realized that I have never had a sexual relationship that has been about me wanting anything. And I was like, okay, that is a really, really big insight. This is something that I suspected from what we had been talking about and how the difficulty she had in when we were talking about pleasure, being able to enumerate pleasure for herself at all. It was always in the context of what her partner liked and enjoyed. So I was suspecting that, but I loved that she was able to get there on her own and understand that, this is not even a concept that I understand around pleasure being for me. And I think many, many, many of the folks that we work with will have that same experience or some semblance of it. So it's important to know that. Break out of your sexual script. So this is where we get into something that you were saying earlier around sex equals intercourse or sex equals some sort of penetration. One of the things that sex therapists do a lot is try to expand the sexual script. Does everybody understand what I mean when I'm talking about the sexual script with your couples? If you don't, just ask them to describe a typical sexual interaction or encounter for them, and they'll typically be able to kind of play that script out for you. Like what typically happens when the two of you have sex? What typically happens? Who starts? What do you do? When do the clothes come off? How do you know? All those things will kind of give you an idea of what this couple's sexual script looks like. And couples, depending on the length of time they've been together, they may have a number of scripts, or they may have one script that is kind of how they do sex every time. But it's helpful to understand what that script looks like for them, because during pregnancy and postpartum is a wonderful time for them to start expanding the script and talking about lots of other ways that you can enjoy each other physically that don't necessarily have anything to do with penetration, that may have to do with lots of other ways of pleasuring each other. Changing in position, someone mentioned this. Sometimes rear entry, side-by-side positioning can be more comfortable in later months if penetration is desired. And if dildos, vibrators are used for arousal or penetration, you're communicating as well about the comfort level of those as pregnancy progresses and in early pregnancy as well. What are some ideas that you all have given to your clients about pregnancy sex and how to help that work?
I give them a handout.
Okay. And what's on the handout?
It's like, orthopedic. Well, just like to think outside of the script a bit, right?
Okay.
If the positions and their go-to positions aren't working for them, it's like there's a bunch of positions. Like just get a view of this.
Okay.
It's all broken down to like if you have back pain, You know, if you have this position gives you, you know, access to clitoral stimulation.
Okay.
This, you know, it just breaks it down to all the benefits and the cons, and so it helps them expand out of like, I just can't.
That's
do it
great.
This way. It's just one quick way.
Yeah.
And then they can take it home to their partner, which is.
Yeah. I also love those the wedges, like the Liberator, I think is one brand where there are a variety of different wedges and shapes that you can buy to have that they prop you in different positions, and you can use them for different sorts of positioning during sex. Those are also pretty helpful for some folks. You can also use pillows to do it, but they're a firmer sort of foam, so they kind of keep their position a little bit better.
It's hard to answer that because it's so individualized.
It is very
and
individualized.
So it's like specific to the client.
Uh-huh.
I think the one broad thing that I do bring up with my clients is the reminder that masturbation is legit. And if all this is just not working, or they're feeling embarrassed by their body, they have vulvar varicosities that they're worried about, or that their partner they fear that, but they're having an increased desire for that, or their partner is not into it. I'm like, go be jamming on your own. Like, this is just have some fun.
It's a great tip.
And remember that your body is beautiful and meant to bring you joy.
Yes.
I often give advice, like similar advice, but for the other partner, right? That like taking the pressure off of penetrative sex, taking the pressure off of like also like everybody has to climax all the time, otherwise everyone's failed. Yeah. And sort of refocus on like the joy and the pleasure of connecting, but then also like embracing the like, and no matter what happens, there should also be like the opportunity for one or the other of you to do whatever you need to do, right? If one of you really does want to climax and the other doesn't, like that should be like celebrated, and like, you know, you shouldn't feel pressure to like have to like do something that you don't feel like doing, or keep going if you don't. You know, and there is nothing wrong if your partner wants to masturbate to finish, or if you right, like, because I think that there's a sense of like, well, if you don't finish, then I don't get to finish, and like, you know, I don't want to have to help you finish, or like all of this, like, who get, you know, like fairness, and
I think it's also you're home on a Thursday and you're feeling it. You don't want to deal with coming home and having that whole thing, you know, just that freedom to just be free to be sexual.
Absolutely.
So with the high risk pregnancies, that's what keeps coming to my mind. You know, all this can be super challenging, but each of the bullets is really important because communicate. So for example, someone that, well, I'll self-disclose here. I have always had high risk pregnancies, and starting at like the minute I found out I was pregnant, I was not allowed to have any stimulation on my own. Like I could not have an orgasm. I wasn't on.
No orgasms for you at all. Okay.
For the entire pregnancy.
For the entire pregnancy.
Because I start contracting really, like at like 13 weeks, I would start contracting. So I couldn't, you know, your uterus stimulates even more if you have an orgasm. So in my case, it was quite interesting because my husband and I had to communicate a lot and be a little creative because it was just a long road. And so with mastery, I mean, it's like he wouldn't have made it otherwise probably, but that's
really helpful.
So it's I think it's there's a lot of different, like you were saying, scenarios that fall into this, and it's not. We would love if it were all where you just have sex the entire time, but that doesn't always work for.
Not for everybody.
But I'm actually surprised how many like female partners are uncomfortable with their male partners masturbating.
I was gonna bring that up. Yep, I was gonna bring that up. So masturbation is kind of the last taboo, I have to say, even among sex therapy clients. I mean, like it is really hard for people to talk about masturbation. I also have a specialty in working with conservative religious clients as well. So it's particularly challenging if your religious beliefs either prohibit or place a lot of shame around masturbation. And I have a lot of clients who come out of those traditions. They may still be in those traditions, or I have a lot of clients who have left those traditions but are still struggling with the shame around certain aspects of their sexuality. And masturbation is typically way up there on the list. So what do I have to say about that? We need to be talking about it.
There's actually a question. If you build an OkCupid like profile-y thing, there is a question that says, do you consider your partner masturbating and
Yes.
cheating?
Yes.
Wow.
Yep.
And lots of people say yes.
Lots of people say yes. Yes.
And they
Lots of people say
consider
yes.
cheating.
Because within someone say two things. Maybe I'm gonna get off on a soapbox, but I'll come right back, I promise. Two things. Within some conservative traditions, masturbation is thought to be sex with someone other than your partner. So that's yourself. And so that is infidelity. So there are a variety of conservative traditions who believe that. And also, if you are being treated for sex addiction, which is a little bit of a controversial concept within my field as a certified sex therapist. I'm not a sex addiction therapist. I'm not trained in that model. I'm trained in a different model, which is out of control sexual behavior, which doesn't view it as an addiction so much. And if you want to talk to me about that, you can talk to me about that later. The point is that in many sex addiction treatment programs, you are not allowed to masturbate. So, masturbation is kind of important in so many ways to get to know your own body, to get to know what you like, then to be able to share that with your partner. During times when your partner cannot have sex with you for medical reasons, for physical health, chronic disabilities, so there are a lot of reasons why masturbation can be very important. That said, when I'm working with a client who does not believe masturbation is okay, then we figure out other ways to work around that. I don't tell people they have to masturbate for sure. I don't violate people's religious beliefs. We do explore them. We do explore them and talk about them and investigate kind of what what's underneath there and how much wiggle room do we have? And if we have none, then we don't do that. And if we have some, we think about, ways to be creative around that. But that said, the reason I got on that soapbox is to come right back around to what you say, is that if you don't talk about it, you may not know that it's not okay in this partnership to masturbate. Mm-hmm. So carefully investigate that before you begin to talk about it, because I'm a big advocate of what I call self-pleasure. Sometimes I don't even use the word masturbate because it brings up so much shame and guilt and weirdness for people. So I will often say solo sex or self-pleasure instead to help people. If you use those words though, sometimes people go, what? Are you talking about masturbation? So, sometimes that doesn't work either. But I'm trying to kind of remove the stigma from that word and help people to be comfortable talking about it. I'm also a big lover of sex toys and helping people discover sex toys that can help them, especially in this period. It can be great. A vibrator can be your friend, not if you're in that sort of high-risk pregnancy, of course, but if, vibrators can be your friend. So there are lots of good sex toy stores out there that you can go to, and the folks there will help you figure out and let you hold the vibrators and, feel what they feel like in your hand. And they can tell you some things about them. So that can also be something that you can educate your clients about. It's good for you too to educate yourself about different sorts of vibrators, but at least the categories and how they work, so that you can help your clients to perhaps make that purchase if they haven't. Some of the most fun work I do is to help people who have never masturbated but who want to explore that part of themselves and to get to know their bodies. It can be incredibly rewarding to have someone just touch themselves for the first time, or take a mirror and look at their body and just be like, whoa, this is cool. And sometimes during pregnancy, it's a really amazing time to have them do that, because look at what my body's doing. It can be kind of a counterpoint to all the body image stuff that pregnant partners kind of have during this time, where they feel like their body is ugly, it's changing, it's big, it's, I'm a elephant, whatever. let's see. Anything else that you guys think about around pregnancy? I love this one so much. I love this one. Yeah. Yeah. So sexy little nothings. So let's talk about trauma. And I am not a doctor, but I did want to put these things here. So we're going to start talking about childbirth a bit and some of the things that can happen emotionally and also physically. So these are the degrees of trauma that can occur in the body. Those of you who are medical professionals, can you weigh in? Would you like to weigh in on any of these sorts of trauma that occur during childbirth? Just impact on the folks that you work with and impact then on sexuality.
Well, third and fourth degree, I mean, you can read that. But so many times our patients are terrified to have another child.
Yeah.
And then it's a planned C-section because they don't want to go through this, or it's like the birth plan is made of concrete, and if anything changes in it, it's like everything spirals out of control. Like, and it's not a positive experience in any way. And the second degree is most common in your first delivery.
Yeah.
It's most common in your first delivery.
I would say it differs with hospital.
Yeah.
Okay.
Only about 5% of my clients too.
Okay.
So
At all.
they might have some little skid marks, but that shouldn't be.
And how do you, can you talk a bit about that? How does that occur?
Well, it's hard because I'm not on the other side, right? What I see is a lot of people feeling very proud of themselves and their vagina and their perineum and their vulva for being so strong,
Okay.
and being so perfectly accommodating to their baby, and for having slowed down just when they need. It's just a lot of empowerment, which I think maybe bleeds into then feeling that way about the return of sexuality in postpartum.
Okay, that's great.
But I will say that, like you alluded to, the third and fourth degree folks, which are extremely rare.
Pretty rare, yeah.
There's a lot. That usually means a fairly traumatic delivery anyway. And then, so there's a lot wrapped up in there that's not even just physical.
Yeah.
Especially with the fourth degree.
Yeah.
So, but
Yeah.
people are super proud of themselves when they don't need stitches after.
Yeah.
They're really proud.
But also like communicating like on the other side, like if it happens, you fail.
Yeah.
And so many
Sure.
people are like, oh my God, I'm, like my body didn't work right, and now I need stitches in my vagina. What's wrong with me? And there's this huge thing. It's like, well, your baby came out with its hand up here and tore you.
Yeah.
So it came out. So it was like, and you try to do all these things like delivering your knees and doing all this stuff, and it like still happened. And so seeing those women like blame themselves for, I'm like, no, like it just, you can't control the position of the baby all the time.
That is interesting. I've actually never worked with someone who felt bad because they tore.
Because they had a tear.
Did I push wrong?
I mean, they
Did
have
I
like
push
they
too
have
fast?
other feelings,
Did
right?
I,
about
did
tearing
I not
it
push
up.
enough? Did I push too quick? Did I
Did I not do enough perineal massage?
did I not do enough back compresses? Should I stretch throughout the like,
And then we come right back to, no, your baby is so smart and you
Yeah.
and found a door.
yeah. Baby's coming, let's come.
So let's talk about physiology postpartum. So one of the things that, well, all of these things can happen. One of the specialty areas that I work in is postpartum mood disorders. And so we want to educate our clients about what happens hormonally after birth and the difference between what we call the baby blues, which happens in about 80 to 85%, of women postpartum and postpartum mood disorders, which tend to go beyond that 2 to 3 to 4 week period that baby blues occurs. But we do see lots of fluctuation in mood after childbirth. Sometimes people describe feeling just fine and then feeling very cheerful and then feeling very anxious. I have seen in my practice a lot more in the last, I would say, 5 years, postpartum anxiety than postpartum depression. Everybody's, lots of head nods. Okay, so that's what I'm seeing as well. I don't really know how to explain that because a number of years ago I was seeing more depression and now I'm seeing more anxiety. I don't know. But it's important to know that there are significant mood changes which can be surprising to both partners in the couple. You can have some vaginal dryness, you can have thinning of the vaginal tissues. Obviously, you can have significant fatigue, not just because of sleep deprivation, but because of the experience of childbirth itself as well, depending on the delivery and all of those things. My pelvic floor person can probably speak much more to pelvic floor stuff than I can, but what my clients have described is that it feels looser down there. Breast soreness and engorgement, particularly in breastfeeding moms. And then just this touch overload can be a really big deal for moms during this period, feeling that there's something on me all day long and I really don't want you to touch me at all. Can be difficult for both partners in different ways. It can be very difficult for the partner, not the mom, because there's no touch happening. And often they're already feeling a little bit distant and outside the bubble of the breastfeeding mom and the baby. And so that lack of any touch can really make them feel distant. And interestingly, for the mom who isn't wanting to be touched, the mom also may feel that lack of touch, even though not desiring it. There is some distance from the partner that's difficult from not receiving it. So weirdly, you don't want it, but you also can kind of suffer from not having any sort of touch at all. What I find with my clients a lot is that they're worried that if there's any touch, then their partner's going to want to go further with that touch and have sex, and they are not in for that, not down for that. So then we just don't touch at all, so we don't mislead anyone. So then we're going to go back up to that top of that last slide, which is communicate, communicate, communicate. I talk to people a lot about be willing to say up front, I really want a hug. That's all. I just want a hug. That's all. I don't want to do. Can I have a kiss? Can we snuggle a little bit before we fall asleep? But I'm just not up for sex right now. And then help your partners be able to receive that as well. Not as rejection, not as you're not a good lover, I don't want to be with you, but as just not ready just yet. I'm feeling touched out from the baby. The Bring a Baby Home class is fabulous around helping partners to prepare for this aspect, for lots of aspects. It doesn't do as great a job with sex. Depends on who you take it from. If you take it from somebody who has sexuality training, they're going to throw the sexuality in there, which is kind of what I did. But the actual Bring a Baby Home itself does have a module on sexuality, which is pretty good, but it doesn't get into to me, the down and dirty of, what do you need to do about sexuality? But it is good for preparing partners for this period where the withdrawal from physical touch becomes really hard. And they have the couples during the training kind of prepare a plan for how are we going to touch and remain connected after our baby comes. Are we going to, cuddle in bed? Are we going to make sure that we have a kiss when, we come back together after a long day? Creating some rituals of connection can be really, really important during that period.
What's interesting is that, I've worked with a lot of couples where dad is staying at home and still in a heterosexual relationship.
Mhm.
And some of the things that we often like equate to like being like a mom thing is
Mhm.
actually, it's really a caregiver thing.
It's a caregiver thing.
And
Good
it's
point.
like as soon as the roles are reversed, it's actually really similar. It's
Yeah.
like I've been spit up and like yelled at and cried at and
All
you know,
day.
all day long, and I'm tired and worn out, and like I don't have anything left for you.
Yeah.
Right, my partner. And like that was like I think really eye opening for me
It's a really
because
good
now I can actually share that with my clients and talk about it being a caregiver,
caregiver
issue
problem.
and not a mom and a dad or a
Yeah.
gendered issue or like you know.
Mhm. That's
it's
a very
more
good
like
point.
Roles.
It is really a caregiver. It is really a caregiver issue. And if you flip or if you have a period of time where the other partner's caring for the baby, then you may have that be reversed. That's a really good point. Yeah.
I remember I went to a class or conference, it was last year, and we learned about like caring mood disorders, but it was like the intimacy of doing a 2-minute hug.
Mhm.
And I love that. And so I like tell everybody.
Yeah. Yeah.
And I tell them why. I told my friends, I told my mom, I tell all my patients, like, just hug and set a timer because 2 minutes is a long time.
It's a long time. Yep. It's a long time.
Because it's the oxytocin in a woman and it reaches the man. And I'm like, I just thought it was the nicest.
Mhm. That is a
So
really
I
nice
like
thing.
talk about that.
That's great. I love the 2-minute hug. And also, there's another strategy that's just called hugging until relaxed, which is another strategy. And it's similar. And usually within that 2 minutes, you're going to get to relax. But the idea is that you hug until both partners feel their body relax into the hug. So depending on how stressed you are and how bad of a day you've had and how long the baby was screaming just before, it may take longer than 2 minutes, but usually within that 2 minutes, you've had time for your bodies to kind of, you feel that full relaxation kind of starting from here and down. And I think that's a great strategy. And it's certainly a great strategy when you're exhausted and there's really not much else you feel up to. You know, you can definitely, you know, kind of lay in a hug and relax with each other for sure. Yeah.
I wanted to mention something.
Yes.
One thing of value that you guys, that I've learned over the years working with women in PT and for 20 years, and you reflected back, it used to be postpartum depression that we're worried about.
Yes.
And that was the big deal, right? And it's like, it's transitioning very much so into anxiety and anxiety, depression, that sort of thing. What I've noticed in pelvic floors and how we hold our anxiety, trying to communicate, etc., that the pelvic floors are getting tighter.
Interesting.
Like, even in the prenatal period. So whereas maybe it was before, like every woman could do Kegels or they could do Kegels, and that was, I think that was reflective of the times actually. I think that was fair enough. But things are switching. We have a collective anxiety field that we're working within. We feel it, and then everything is scheduled down to the minute. And you know, when I'm watching people as a PT, like sitting, you know, like to do the work, and like it's like they're not even just sitting in their seat. You know, it's like if you guys try that even right now, like squeeze your rear together a little bit, like to be sit upright and then release down. It really makes a big difference in that holding pattern in the pelvic floor. And more of us are doing that holding pattern.
Yeah.
Yeah, just noticing, like, are we even sitting on the surface? So that's where in the prenatal time, it's I love to be able to help women assess their pelvic floor before they need, they're called to release those muscles and yield in childbirth. So I created, I should have just brought a bunch of flyers or brochures for you guys, but it's prepare your self-assessment for women, pelvic floor self-assessment for women. So, and I'm doing it in women. I see women in my home practice. I really specify that people who identify as women and have the anatomy as women.
Okay.
Female assigned.
Yeah.
And so that they can start figuring out, like, do I have a tight pelvic floor or do I not? Or am I the person who should be doing Kegels all the time, right? And can we address that and release that, get it prepared for birth before the birthing happens? So it's just useful.
Yeah.
So in the
Yes, absolutely.
yeah.
Yeah.
And it shows up in postpartum too.
So let's talk about sex after childbirth. So 4 to 6 weeks is that typical when the doctor has a postpartum check and will say, all systems are go, you can have sex now. 4 to 6 weeks is that typical recommendation. These are percentages about when people actually resume having sex. So at 6 weeks, 41% of folks, 12 weeks, 78% of folks, and 6 months, 90 to 94% of folks have. And what we mean by that is have resumed.
I've had it.
They have had sex once, right? They have had some form of
Like,
sex.
what exactly does that
Yeah,
mean?
what does that exactly mean? They have had sex once together. Some form of sexual, I don't know if the definition was intercourse and in the particular studies that give us these statistics, but yeah. So a little bit of talk about the transition that people are going through to become parents, right? We talk about the we to three. So it used to be that in a couple, we only had to take care of each other and we're both adults. So there wasn't as much to take care of when we were a couple as when we have this very small, helpless person, and we are now three, and both of these adults are very consumed with care for this helpless being that has come. So we're no longer just we're three. The motherhood, fatherhood, caregiver, we could call it the caregiver transition, right? So when you're becoming a caregiver, I've had a lot of couples talk to me after that they realize when they leave the hospital, if they're in a hospital, that somebody handed them this baby and said, go forth. And they were like, what? Like, I don't know what to do. Are you me? Like, I'm going to be the one who's going to be the caregiver for this baby? And I don't know. So there's this sense of responsibility for another person. The majority of people have not experienced that up until this point. Not that sort of responsibility for another person. So it's quite a transition for a lot of folks to becoming a caregiver for another human being. Sometimes partnerships move into more traditional gender roles. And what I mean by that is often for a period of time, one parent is staying at home with and not going out to work. So they are caregiving, as you said, full time for a period of time for the kiddo when the other partner is going out and working. And often this is the only time in their relationship when that has occurred. When somebody leaves the home and goes and somebody stays at home, it's like that Leave It to Beaver sort of thing where they're like, this is not us. I have a lot of couples who are very discombobulated by that idea of we're now in this kind of weird traditional kind of looking relationship and really am I the one taking out the garbage now because I'm staying at home? What? So there's a lot of conflict that can arise around role change, just this in general, this role transition for folks that happens. Doesn't happen for everyone. It's unique to, whatever person you're working with, you're going to find out, but some of these things do happen. Lots of emotional changes. We talked about that with the mood issues, also with lots of anxieties. People have anxieties about lots of different things during this period. Some people are horrified that the baby is not breathing, so they're checking the baby's breathing often. Sometimes they're very anxious about their own body and what's happening in their own body and changes in their body kind of moving back toward normal. Sometimes they're really anxious about their relationship because for the first time they're kind of fighting a lot, or there's a lot of tension. They're very irritable with each other when they have not been. And so there's a lot of fear about what's happening to our relationship. We were never that couple that fights, and now we're fighting about lots of different things. So that can be really concerning for folks. The birth experience and its impact. Birth trauma. There's a book in the resources written by Penny Simpkins, When Survivors Give Birth. That's a really good book, if you have folks who have significant trauma in their background and are giving birth, it covers a great variety of things that can happen for trauma survivors during childbirth. Any wisdom you'd like to share from your clients around what impact trauma can have in childbirth, and then what happens for that after that, as far as the impact on the couple?
Decrease in sex,
The decrease in sex, for sure.
if not completely stop.
Yeah, sometimes completely stopping. Sure.
I think we all need to be reading that book. Everybody.
It's a good book.
We all,
Mhm. It's a great
or
book.
be trauma informed, because period.
Right.
Because we can't just wait for the 1 in 3 statistic, you
Yeah.
know, to show up for
Yeah.
sex, because it's all of us.
Yeah.
You know, and we all have these. Huh? Yeah, 3 and 3, right?
Mhm.
You know, and it's just in some way we have deep imprints, whether we know them or not, and we're disconnected a lot of times from our pelvic pools or pelvic floors or sexuality, from
Mhm.
pleasure, and we're coming back into reconnection with these areas that we somehow got by with, but then now we're taking a look, preparing for childbirth, and things come up.
Yeah.
Yeah, things come up, and we've got to be ready to help them.
And if you're working with folks, I do always ask in the preliminary intake interview about the birth experience, and just have the couple tell me their story, just in their own words. And you will often be able to gather if there are trauma points within that story. Sometimes you'll be able to hear those in the retelling. They may not identify it as trauma, but you may be able to pick up on some things that have occurred that were traumatic for them during the childbirth experience. It can be very difficult when the birth doesn't go according to plan. You are making a note of that. So if things go very differently from the way that I expected it to, that can be really scary for folks. It can be give them a great feeling of helplessness because they weren't able to control what happened. So you want to be really aware of those instances in which folks felt out of control of their body, out of control of the experience. Perhaps there were medical things that occurred that they weren't expecting or that were very frightening. Those are pretty important things to listen for in the retelling, because if you've had those sorts of experiences during childbirth, sometimes when you begin to re-enter sexuality with your partner, those things can create some real anxieties around your body again being open, your body again being helpless or vulnerable to another person. And it can be not expected. The first sexual experience can be quite frightening for a person who wasn't expecting that trauma to surface at that point. Also, pain can definitely trigger those fears and traumas from childbirth. So if the first sexual experience is painful, that can also be a triggering thing for folks to have happen. So for them to be aware of that can be really helpful. And the book is extensive, so I would really recommend you reading that book at some point, or others around trauma, just basic trauma work. You can read The Body Keeps the Score. You can read the Tiger, Peter Levine's work. Those books around somatic work with trauma, I think, are super. Even if you don't do somatic work yourself, I think it's super helpful to have a trauma-informed approach and to know how much we hold trauma in our body. And often releasing trauma has to do with releasing the trauma from our body. So I think those are really good readings to have as kind of a basic. I recommend for folks that I supervise in therapy that, again, even if you're not going to become a somatic or Hakomi or, a practitioner of those sorts of psychotherapies, that you take at least 1 or 2 trauma classes so that you kind of get a background in that.
I was going to say, I think Amy also teaches workshop on that.
That would be great.
On,
Yeah.
survivors.
I think one of the things that I often talk about with my clients around trauma is the impact it has on any of your interpersonal relationships, like is one of the biggest things. And so like, you know, you might not necessarily equate birth trauma with having an impact on your relationship, but it does.
Yeah.
It impacts all your relationships and sort of like educating them on that. And then the other thing is that I'll just say, and I'm sure you all see this too, is that I'm very rarely getting someone in my office during pregnancy. It doesn't happen that often that we're working on like an earlier sexual trauma before they give birth. It's always after, when they didn't know there was going to be anything that related to their sexual trauma that would come up, you know, during their childbirth. And so it's like, I always am just like, you know, I just have this like, I just wish I could like go back, you know, and you know, have met with them, you know, during pregnancy or before, and like their providers never even saying to them, like this could be something that could, like they don't, like they're not aware of it. And so I think that it makes it even worse because they feel like when I tell them that like that's a common thing, like that doesn't necessarily reassure them because then they're like, well, what the fuck? Why didn't someone tell me?
Yeah.
You know, like why, like if this is common and you know this and you could have told me this before, then why didn't somebody else, you know?
That's really helpful to know. And it's definitely, I get often the, I guess, honor privilege of working with folks before as they're trying to get pregnant and then they do. So often I do get to talk with people ahead of time, which I think is super helpful to do. We do talk about knowing your trauma history. Let's talk about some ways this experience could be difficult for you. So having those conversations beforehand can be so helpful, but so many people don't get to have them. I think that's really important. So all of you who are therapists, you might, and other folks too, birth doula, every one of you actually in this room might get the opportunity to be able to talk to people beforehand and kind of prepare them in some way for how the birth experience could bring up some of those things. So that's a super helpful conversation to begin having really early on.
It's also really important when you have students or people that you work with that you're supervising or whatnot.
Yeah.
Because it's something that I talk about in the very first intake with every single client.
Yes.
And when I have a new student, that's one of the first things that I make them figure out how they want to broach that subject. Because none of them want to.
Right.
They don't want to because it's uncomfortable. It's really because you are just confronting this big giant thing.
Yes.
That one could then bring up things right then and there that they're like, I don't know what to do with that. Or that they just get that like, nope, not me. Wasn't me.
Yes.
You know?
Yes.
And then you're like, okay, how are we going to burn this back up later? But it is one of the first things that I have them like kind of hone. How are you going to open this conversation?
I love that.
And
love
open
that.
this door because that's what it is. When they present it to the client, I'm like, I've just met you, but I'm going to open this door.
Yes.
Because pregnancy,
Got to.
labor, and breastfeeding.
Yes, breastfeeding
all
too.
Of these
Yep.
things can be affected
Yes.
by this, and you might not know that.
Yes.
Let's take this time
Yep.
to work it out so that it's not in the middle of your labor.
Right, when we discover this,
when
which I
you're
think is
flashing
great.
back and then like, well, too late now.
Yeah, I love that. And what I love most about that is having people rehearse how they're going to bring up the conversation, right? When I work with new sex therapists, and I also do a class for how to talk about sex if you're not a sex therapist. So I also do some training with people who, this is not what they do. They're not going to be a certified sex. They're not going to talk about sex all day like I do, but they're going to have clients in their office. And the first thing I talk about is you got to get comfortable with asking the questions. So I don't want to tell you how to ask the questions because I have a certain way of doing my sexual health history that is unique to me, the way I talk about sex. You need to develop the way you're going to ask the questions. And that's what I love about that. How are you going to bring it up? Practice it in your office or with your colleagues. Do it over and over and over again until you can say the word. I got to tell you a funny story. So I'm working in an agency a number of years back, and they know me as the sex lady, right? Because I'm going through sex therapy certification training during this time. So every consult group that we meet in, I'm the one who says, well, what about the sex? What about, did you ask them about sex? What about masturbation? What? You know, so we have this consult and I bring it up and I say something about, what about the sex? And this therapist, who happens to be male, there's nobody male in here so I can say it, happens to be a male identifying person who says, I can't even say penis without blushing. And I'm like, okay. I said, so here's what we're gonna do at lunch, you and me. I said, we're gonna go in your office and I'm gonna sit on your couch. I'm gonna be your client and you're gonna say penis like 50 times until you can say it without, well, I'm serious. Like make up a question about the penis and you're gonna say it and say it and say it and say it until you've, exposed yourself enough, using that term, that's not a very good term to use, but this is exposure therapy, right? I'm going to say it and say it and say it and say it until I can say it. That's funny, but I mean, he did not want to do it. Like, it was like, I am not doing that with you. I'm like, okay, well, do it by yourself. Do it by yourself until you can just say it and say, and that's what I mean. Like, practice the question that's the hardest for you to ask. Get a colleague, get a friend, or do it in your office by yourself until that just rolls off your tongue. Because clients pick up on our anxiety, right? They're scared to talk about, they're coming to a therapist, they're scared anyway. They're coming in there to talk about stuff that's super vulnerable, even if they're not coming to talk about sex. So if we say, well, do you masturbate? Then they're going to pick up on our conflict about asking that question. But if it rolls off just like, tell me how, have you ever had, tell me about your early school experiences. Tell me about who raised you. Tell me about how often do you masturbate. It's just a question, just like anything else in the intake. Doesn't mean your clients are going to be like, great, let's talk about this, but you're at least not adding to their anxiety about it. So practice, I think that's a great point, is practice how you're going to ask it, how you're going to talk about it. Great point. Okay, body image issues, what can we say about that? We're not good. We're not good in our culture with feeling good about our bodies when they don't look exactly like we think they should look. That's all the way from how I look fully clothed to what my labia look like, right? I mean, it's everything. It's everything, and none of us are really immune to that. And particularly women after birth, huge issues around how they look, around their bodies change, their bodies shifted, things look different, things feel different. We need to be talking about it. We need to be supportive and kind, but also understanding and not dismiss those. And you look great. You look terrific. Not if you don't feel it. We got to be willing to, venture into those conversations with folks about how they feel about their bodies.
Can I add two things?
Yeah. Oh, absolutely. Yeah.
So I see people several times in the first week postpartum, and then I see them every 1 to 2 weeks for 2 months.
Beautiful.
And I start talking about sexuality around week 2 to 3.
Okay.
Because the earliest I've known people to resume penis and orifice intercourse is 2 days.
Okay.
postpartum.
Okay.
And which is kind of funny considering one of the first slides, which is they don't know that they could get pregnant.
Yes. We're gonna talk
And
about
so
birth.
that's
Mhm.
when we
Yeah.
start talking about how to make it pleasurable.
Yes.
And also what to do instead of,
Yes.
so that they can stay physically safe and also
Absolutely.
whatever they want to enjoy. And then the third bullet point
Mhm.
is this is actually, I think, a really important conversation prenatally.
Mhm.
I encourage clients to have a date night where they go out and that's what they talk about. I say, talk about what it's going to be like when both of you are sleep deprived for a month, because I am up to here with hearing I get 3 hours of sleep because my partner has to go to work, so they're sleeping for 10 hours.
We hear that a lot.
So
Yep, I hear that too.
Everybody
Huge.
is sleep deprived.
Yeah, everybody's sleep deprived. Yeah.
How are you going to do that?
Yeah.
So that they have a plan going into that transition.
Yes.
And it's not
We
a
do that and bring a baby home
surprise
too. Yeah.
When,
Yeah.
when the birthing person is sweating, bleeding, crying,
Yes.
peeing herself.
Yep.
And the other person's like, what's up? Like, why are you?
And I gotta go to
such a
work.
mess, you
Yeah.
know?
Yeah.
So I think that's
Super important. Yes. That's something we do and bring a baby home as well. And very good conversations to have. This is Olaf. Love Olaf screaming. Hands up. So, yes, with pain, can we have pain? Yes, we can. Are we supposed to end at 8:30? Okay, I'm watching my time. All right, low estrogen levels in the vagina. Very often seen in breastfeeding women. Sometimes vaginal estrogen cream can help with that. Problems with scar or nerve pain. So the tissues, if you do have tearing, can heal together, creating a web of tissue at the vaginal opening. You can have nerve injuring or stretching sometimes. And then muscle spasm, this is our pelvic floor stuff, can become very tight, as you were talking about, can happen after either vaginal or cesarean birth. And we think it could be caused by rapid withdrawal of progesterone after birth. So can you have pain after childbirth with your first sexual experience and following? Yes, you definitely can. Can we work with the pain? Yes, we're going to do that. Let's talk about what we're going to do, because let's get to what we're going to do. First, that's beautiful. You're meeting with people very frequently, it sounds like, after. That's not the traditional medical model, though, I don't think. I think it's like a follow-up at like 4 weeks or 6 weeks or 6 weeks, 6 or 8 weeks. Okay. So understand that we got a big difference.
Right? But I said 2 weeks for the baby.
2 weeks for the
not
baby.
for the mom.
And yeah, 6 weeks for the mom or 8 weeks for the mom.
We'll do a
So,
exam.
okay, at 6, okay. So understand then that the clients you have, because I'm having more of my clients who are doing therapy with me during the pregnancy continue their therapy much more after than they were able to before, because we have telehealth now. So I have had, like, the last pregnant client I had, I mean, I was talking to them like 4 days after the baby was born. They were home from the hospital and we were having a telehealth appointment. So this is new for me, because I mean, it used to be like, I won't see you again until you can get out of the house and bring the baby with you and all of those things. So I'm getting to have more contact with my moms after, and my partners after birth, but much sooner. So at that point, you can be kind of first point of contact for maybe they do need to see a medical professional before that 6 week or 8 week check, right? If something's going on physically, if they're having anxiety, if you're suspecting some mood disorder going on there, maybe that you can be a point of contact to say, maybe you should check in with your doctor, maybe you should check in with your midwife, maybe you should check in with your doula, whoever is your, providing professional, you can be the point of contact on that. Hopefully what they're going to do is investigate, evaluate where the pain is coming from, what's going on. They may be recommendations for pelvic floor therapy, for estrogen. This is a point at which we definitely want to be discussing birth control. Many, 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 many people don't talk about birth control because they're assuming that people aren't having sex. This is a problem because people are having sex.
And
2
then they
days.
come back to their final postpartum pregnant.
Pregnant. Yes. So many, many, many times. So be aware that you also may be the first point of contact for people to talk about birth control and to talk about the fact that breastfeeding is not birth control. I'll say that again. Breastfeeding is not birth control. It's not effective. I don't even know what the statistics are. But do what? 1 in 4 chance. Okay, good. Thank you very much. So not a good birth control. Lubricants. I talk to clients if they, sometimes pregnancy or postpartum is the first time that a female identifying partner has needed to use lubricant. So sometimes they don't have any. Sometimes they don't know which one to go and buy. So talk to them about lubricant during pregnancy, definitely postpartum. And I talk to people about using much more lubricant than you think you're going to need. First time, especially the first time.
Do you have a recommendation on types, like water-based, oil-based?
I was like, well, which one is it?
Yes, I do. Yes, I do. And I was going to I have a chart actually of lubricants and the ones that, so maybe if I can get that to you all, can you post that for everybody? Yeah, I'm sorry. I left my office really fast and I was going to bring that folder, and I have a lubricant handout that I give to people that basically talks about silicone-based, water-based, what works best for this or that. And it's a little bit dated, so the brand names, some of them are still out there and some of them are not, but it's a good starter, for people to absolutely talk about lubricant. I actually keep some samples of lubricants in my office as well for people so that we can like talk about them. I can even open the packet and we can feel them together because again, demystify. The more demystifying, I also have sex toys in my office too. So you can see what a vibrator looks like and see what they, you don't have to have that, but I mean, just the more familiarity, you help people to see, oh, this is not scary. Here's a silicone lube, feel that. Here's a water-based lube, feel that. And let's talk about the different sorts of lubricants you're going to use for things. I'm surprised, really surprised at how many people feel like lubricant means there's something wrong with you. And how many partners feel that using lubricant means I'm not a good lover. So we got to get that out of there. We really got to get that. I mean, I talk with people very openly about understand that the body does what the body does, and you may be doing great things and you may not be lubricated enough. Even if you're turned on, even if your brain is turned on, it does not mean that your body's going to produce enough lubrication for you to comfortably have sex. So the more you can talk about that, the better, and really just tell people, get some lubricant. Have it on hand, have it at the bedside, try different kinds. I'm really big on natural as possible, and it's much more possible to get natural, non-additive lubricants now than it was when in the era of my era, which was KY was what you had, all right? So now there's lots of really good ones. You get them on Amazon. You don't even have to go buy them and put them on the counter. You can just get them on Amazon, which is great.
We say recommend a lot of like coconut oils. What we
Sure.
go with is that
Yes.
fine?
Yeah, I have a lot of folks can totally use coconut oil, and it's very natural, very good. Coconut oil can sometimes stain your bedding occasionally, so let people know that that's a possibility with coconut oil. But I find that a lot of people really like that, and it's a really good natural buy in the grocery store. Yeah. Mhm.
Yeah, it's not condom compatible though.
Right.
Oil.
Correct.
I knew it's like oil-based, you can't use it with condoms. And
Right.
Yes,
use that
and the
with
toys, silicone
Right.
toys. Yeah.
So, yeah.
And also the silicone lubes aren't good with the silicone toys either because they break down the silicone. Yeah.
A little tip to tell them about the coconut oil is if they freeze them in little balls, they can pop them in their vagina before sex because it has such a low melting point.
That's a very cool
If you
idea.
tried, it's just gonna melt on your fingers. But if you get like one of those teeny tiny ballers,
Yeah.
That's a very good idea. Love that. Love that idea. Yeah, that's a great idea.
then that way you'll be able to like pump them.
What a great idea. Love it. I love it.
Let's
Yeah.
do this every month.
That's so great. I love it. And then postpartum mood disorders. I mean, we could do, and you've done trainings on that, so I'm not going to go into great detail, but just to understand, have a screening that you do so that you can talk with people about postpartum depression, postpartum anxiety, and kind of get a sense of if you need to refer out for someone to talk to about that particular issue. It's good to know a bit about that. What about my body? Body image issues. So some of the things that you want to know about the body, we talked about breastfeeding a little bit, leaking of fluid during sex. So sometimes the breast will leak or squirt milk during sex. Sometimes that can be disturbing for people, so you want to let them know that that can happen. If they don't like that, they can nurse or pump just before. Some women, partners want to focus on other erotic zones and really don't want their breasts touched because of breastfeeding. There can be soreness, there can be things that are going on there. So this is a great opportunity to expand that sexual script, right? And to communicate. If the breasts have been a big part of their sexual script, then there may need to be some communication about that before the first sexual experience so that people know, I'd rather focus on other zones of the body. I'd rather do some touching. And there are exercises you can help folks do to just explore the whole body and find out which parts of your body are really sensitive to erotic touch. That can be kind of fun to do. Pelvic muscles may feel stretched or looser. You can also have urine leakage during sexuality activity. Kegels can help with that. I'm sure our pelvic floor specialist could also help us with that. The affirmation exercise that I do a lot with people around body image is to just have the female partner alone or with the partner or both kind of stand in front of a mirror every day and just look at their body and pick one thing about their body that they want to affirm that particular day. Doesn't have to be a genital part. It can be, I really think my eyes are nice today. I'm happy for my eyes, or I'm really happy that my breasts are feeding my baby. That's what's happening. Just one positive affirmation that they can do, actually looking at their body. Some women cannot do this naked, and I'm okay with that. I don't tell them they have to be naked. I don't tell them they have to do it in any particular way, but a way that's comfortable for them. Can be incredibly affirming to have their partner do it with them. And if the partner's not able to come up with anything, if the person, the pregnant, the birthing partner is not able to come up with anything, their partner can say something that they think of that they're really thankful for as far as the female partner's body. But just doing that on a regular basis and building up affirmation of the things that your body can do now, the things that your body, even the changes can start to be something that you affirm. But this can also be a very triggering exercise for trauma folks. So just be aware. I use it with people that it seems appropriate for, not with everyone. But it can be helpful to have them do that, focus on their body.
Can I ask just a question though about sort of like, in your experience, folks that are experiencing postpartum depression or anxiety,
Yeah.
like what is, like, is there any intersection with sort of their sexual relationship that's like easily identifiable, or is it just sort of complex and sort of individual? You know what I'm asking?
I'm not sure.
Well, like, are there any like high level things around folks that are depressed and sex in the postpartum period, or high level things?
Connected? You mean connected between sex and the, well, I definitely find that a lot of body image issues in the more depressed folks, for sure. There are often really big issues around, I'm never going to get my body back. I'm never going to be able to have sex again in the way that I was, and I'm never going to be able to be intimate with my partner again. So I definitely see some connection in those sort of thoughts, what I call thought spirals, and postpartum depression. I also see a tight connection between anxious thought spirals around the baby's not going to be okay, or I'm not okay, or our family's not okay, and postpartum anxiety as well. So I do see connections there. As far as sex is concerned, with a lot of my clients who are pretty seriously depressed, we're not talking a lot about sex. Not typically at the beginning when we're really managing the symptoms of the depression. But I also do find that connecting physically with a partner and bringing back some form of physical intimacy, whether it be sexual or not, can be very healing to folks with postpartum depression. If we can, again, disconnect it appropriately from sexual intercourse, such that anxiety doesn't arise around, if I hug my partner, if I really need a hug right now, will it have to go into something else, or can we just do that? Seems really important that you kind of limit and put boundaries around that. Yeah.
I feel like I see a lot of the postpartum depression or anxiety impacting the relationship and impacting the sexual relationship, of course, and then some like sort of rebuilding, reconnecting, or like digging out that has to happen.
Yes,
like,
there is a
later.
lot of digging.
And then like, talking about sex at that point.
Yeah.
So like not necessarily like in the immediate postpartum.
Yeah.
But something that like can really get very disconnected and has to be intentionally worked on.
Yes.
Both the relationship and the sexual relationship.
I think for sure. Oh, I would totally agree. Yeah. So I've not left myself very much time, so let me run. And you're going to have access to the slides. I'm going to have you all put them wherever they can be for people to have. But some things I want to run through about how I talk with clients about healthy postpartum sex. Expect to communicate more. We talked about this. This can be difficult for couples who struggle to communicate before, or for those with conflict in their relationship. We talked about that as far as if there are difficulties before, it's probably going to be difficult after. Expect things to go differently and feel differently than before. How's it going to be different? Arousal can take more time. Positioning may need to be different. Desire may no longer be spontaneous. Teach couples the difference in spontaneous and responsive desire. Does everybody know the difference in spontaneous and the spontaneous desire cycle and the responsive desire cycle? Okay, let me tell you, because this is really important. Quickly, most people think that we end up having sex because we spontaneously have a sexual thought or desire, and then we follow up on it. So I'm walking down the street, I see an attractive person, I go, whoa, that's cool, and I feel something genitally, I feel some arousal, and then I go home to my partner and I'm like, I'm ready, let's have sex. Spontaneous desire, right? Or I'm just doing my work, I'm on my computer, and all of a sudden I'm like, whoa, that sexual experience the other night was really cool. I would like to have sex again. Spontaneous desire, okay? Understand that that is only one way that desire occurs. And many, many people don't experience spontaneous sexual desire, particularly as we age. Our desire cycle tends to be what we call responsive. The responsive desire cycle happens differently. It's, I think that we're going to have sex tonight. Okay, not feeling any desire, really not feeling it. But, you know, it's our sex night. Maybe we schedule sex and that's our sex night. Or I know my partner's interested, and so I'm going to think about it. And what happens is when I begin to engage in intimate experiences with my partner, desire begins to happen as a response to that. That's called a responsive desire cycle. We also know that female identifying persons tend to overwhelmingly fall out in that camp of the responsive desire cycle, which goes back to libido. We said we're going to talk about libido. Many women think I don't have any libido because they're talking about spontaneous sexual desire. That's why they think they don't have any libido. But then I ask women, when you have sex, and we're not talking about pregnant necessarily, but when you have sex, do you enjoy it? Oh yeah, I really get into it. You know, once I get the dishes done and get the kids in bed and everything, you know, we start kissing. I'm like, oh yeah, sex. I remember. That's cool. That's responsive desire. If you do nothing else, teach your clients about responsive desire, because it is really relieving to them that it doesn't mean I'm a non-sexual person if I don't experience regular spontaneous desire. If I respond with desire, just as normal as spontaneous desire. And it means that you got to start something to get something going. Now, does that mean once you start something that you're necessarily going to get going and have the desire? No. And that's when we talk about consent, right? Just because you start something doesn't mean you're going to finish something. I mean, you may be done, right? I mean, you may start and be like, yeah, it's not happening for me tonight. Communicate, so that you and your partner can decide, okay, that's okay. You're going to go masturbate. That's cool. Or I'm going to lay here with you while you masturbate, and I'm not, expand the sexual script, right? There may be lots of different things we can do. That's a very important thing for people to know. If you don't know the book, Come As You Are by Emily Nagoski, please, please, please read it and have all your clients read it. And she's just come out with a workbook to go along with it. And it's wonderful to teach people about this difference in spontaneous and responsive desire and many, many other things about sexuality. It's about female identifying sexuality, but I also have a lot of my male identifying clients who also resonate with a lot of the information in it. Pleasure can be found in unexpected ways. That's that idea again about expanding the script. We just had sex on our kids' Christmas stockings. That's what parents are doing right here. Love it. Healthy postpartum sex. Slow the race to the finish. That's the big O, right? Everybody doesn't have to orgasm. Somebody already brought that up. Explore bodies in new ways. Be open to new pleasure. Emotional connection and resolution of conflict. That idea is you might need to talk about some things before you try to have sex, because there may be tensions that need to be resolved. There may be things that are just lurking there that before you can even be physically intimate that you need to talk about. And of course, those of you who are therapists are going to be teaching your clients healthy resolution of conflict skills. Continue to connect physically when sex is off the table. So one thing that I really find is that often when people aren't having sex, they're not touching at all. So we just stop touching. And people feel so lonely and isolated when there's not even a touch as I pass you in the hallway, or when you're washing dishes, just a pat on the back or a touch on the leg when we're watching TV. So talk to couples about, are you touching at all? Even if you're not having sex right now, can you find some way to incorporate physical touch? Seek breaks from caregiving. Time for the couple to focus on each other. So if you can Find ways to be your non-parent self. It may be what you wear. It may be resuming an activity that you love or having time to yourself. And when people feel comfortable utilizing those people in their life that might take care of the baby for a bit so that you can kind of reconnect, even if it's just to go for a walk or take a nap together. You can be creative. You don't have to go out on a date. You can, just connect in that way, which is really helpful. Lots of lubricant, lots of foreplay, communication, slow down the timing, experiment with positions. We talked about that before. If there's pain, stop. I have lots of people who feel like they need to push through the pain, just push through the pain. Not a good idea. We need to stop and investigate what's going on. Maybe use more lubricant, maybe start with a smaller insertion if you are going for penetration. And then if people are having huge problems with sex, consider referring for therapy. If you're looking for a certified sex therapist, this is a really good directory of those folks who are certified. ASECT is a certifying body that certifies sex therapists. Be aware that there aren't that many of them. And so sometimes they're pretty full in their practices, and you don't have to be certified to have training and to do sex therapy. It's not something that you have to. Some people are looking for a certified. If it's a complex case or really dealing with sex, then you may want someone who's certified. But if not, find someone who has specified training in sex therapy, whether they're certified or not. I think the last count, there are 19 certified sex therapists in Washington State. There are many more coming along that are in the process of becoming certified, but it's a thing to be. I mean, there's a lot of education that has to go along with it. There's a lot of supervised hours to go along with it. So it takes a little bit of time to get certified. So I'm hoping that we're going to get more people through to be certified so that we'll have more folks to do this work. But for right now, I think there may be more now. That was a few months ago. I'm hoping that there are more now, but it's coming along. Okay. Let's see. If the resource list, yeah. So no sex for 6 weeks, but mouth stuff is okay, right? No sex for 12 weeks. Love that doc. Okay, so let's skip this and go to, yeah. So sleep, important. You'll have that slide. I don't want to keep you longer than you're supposed to be kept. So here are some books that I like. It's not at all extensive, but I kind of like these books around sex in general and sex. Understand that The Ultimate Guide to Sex Through Pregnancy and Motherhood is really great, and some of the suggestions I got from that book, and it has a lot of reference in it to kink and alternative lifestyles, which I love. But if your clients are fairly traditional, they might not like that particular book because she talks about rope bondage during pregnancy and stuff like that. So just be aware, I mean, as you would when you recommend a book, that it's cool with the population that you're working with. But I like that it has those references for folks who are involved in different sorts of sex. Yeah. So thank you very much for coming. And if you guys have cards, I would love them. If you have questions, I'll stick around for a few minutes. And thank you so much.
Thank you.
Yeah.
Just a couple quick housekeeping things. If you registered for CEUs, we'll send